coming to the end of a really exciting and long day. What we're going to do now is we're going to discuss pediatric nurse residencies and the programs, which again is an outflow from the IOM report, as we all know. One of your thoughts might be, oh, we're supposed to be talking about undergrad education, but in reality, undergrad education flows into the residency program, so we need to kind of talk about them simultaneously. Our focus, especially tomorrow, will still be on undergrad education, and we'll be taking the residency piece and moving forward so that we'll come back next year and spend more time on that. But we thought that there was a need to at least discuss it. We also have a few questions from the survey that we asked about residency programs so that we can share those with you. So that's what we're up to next, and then we'll just have a brief pulling together of the day, and we'll be able to send you to, as Janice said, we're what stands between your nappy for dinner. So, Janice Smith is our next presenter. She is a member of our board. She has been an awesome member of our board. I've never met anybody more passionate, more detailed-oriented. She's awesome. She's the Director of Clinical Information and Professional Practice. She's at Children's Mercy in Kansas City, and it's my pleasure to introduce Janice.
Good afternoon. It has been a really, really fun day for me, and to be with all of you just really does continue to give me energy. So I probably am not going to tell people very much that you don't already know about nursing residencies, but those of us who represent children's hospitals feel pretty passionately about this topic. So I want to go back up a little bit, and the objectives for me for today are to share a little bit of history around nursing residencies, just to give a short summary of what some purposes, what content areas are like, and how some nursing residencies programs currently are designed. I want to talk about the feedback we got from academic faculty members who completed our survey on what they think nursing residencies might look like. And it's not a lot of detail, but we did ask a few questions of them. I want to make sure to highlight that. And then think about, and probably not today, and although our focus tomorrow will be heavily on undergraduate nursing preparation for practice, one question about pediatric nursing residencies does exist for discussion tomorrow. So if you're a person who is involved in that work, last year the CNO from Children's Boston was in attendance here, and she asked this group why we need all of us each to keep reinventing the same wheel. So I think this kind of a forum gives us an opportunity to be collaborative, to standardize, and to share resources with one another. So I think that that may be an important thing that we can try to do, maybe not this afternoon, but tomorrow, is to try to talk about what the role of the IPN might be in collaborating on pediatric nursing residency programs. I first became a nurse just a little bit before Marlene Creamer described reality shock. And I was shocked when she described reality shock, because my first job in nursing as a diploma graduate was in the pediatric intensive care unit at Milwaukee Children's Hospital, where I worked the evening shift with an LPN, a fellow Columbia Hospital School of Nursing graduate, and then a series of very mature nurses who were working part-time because they had begun raising children and having families. So every night, every evening, 3 to 11, there would be us and this wonderful, very experienced nurse who mentored and precepted us long beyond our orientation period. Now, pediatric critical care in those days was a far cry from what it is now in terms of technology and everything else. But I got to work where I really wanted to work, in an extremely supportive environment. So when people talked about reality shock, I really had not had that experience. But I came to learn that I was really one of the few people who didn't have to experience that conflict between what I had learned in school and then my role and the work environment in my first job. Now, some of that was probably related to the fact I was a diploma graduate, so I'd spent a lot of time already in hospitals. I had had my pediatric experience at Milwaukee Children's and had worked in the critical care unit as a student. So I may not have had as much dissonance between the two. I talk about Marlene Kramer simply to remind people that we are not talking about a new phenomenon. It's not new to talk about the need for new nurses to have some sort of assistance with making a transition to practice as a professional nurse. And then certainly Patricia Benner has been prolific in helping us to understand that nurses develop across time, that we start as novices, and it takes a period of time based on solid education before we are an advanced beginner or competent, and then the further levels of development. More recently, the Joint Commission in 2002 actually made a recommendation that hospitals implement planned comprehensive programs for nursing graduates so that they are able to acquire the knowledge and skills that they need to deliver safe and high quality care. And then you know from other conversations earlier today that residency programs are one of the recommendations of last year's Robert, oh, I put 2011. That was 2010, wasn't it? We're having trouble with dates here. That residency programs are recommended by the IOM, Robert Wood Johnson Foundation, Future of Nursing paper because they really do help us to focus on managing that transition from school to the workplace. They note that most residency programs to date are focused in hospitals on acute care, and that one of the things we really do need to do is to develop and evaluate residency programs outside the acute care setting. Nursing Outlook published in 2009 a survey done by, oh goodness, I've forgotten her first name, Kovner is the last name, and the reference is on the bottom, thank you, of the slides here, where the authors took the words of newly licensed registered nurses and had them describe what the most difficult parts of their transition from school to work were. They talked about expectations that collided and about the difficulty in balancing the beliefs they had about who they would be as professional nurses. So we indoctrinated them to a professional role while they were in school. But then their experiences of very unprofessional behavior when they hit the workplace from their nursing colleagues as well as from colleagues external to nursing. So really a real collision of expectations about their role. Many talked about what they called the need for speed, and that was that they couldn't thoughtfully take care of one or two patients, but they felt pressure to be able to function as well as a highly skilled, experienced nurse could in a very short period of time. Many reported that their period of orientation was shortened and that they were responsible for full patient assignments much earlier than was anticipated when they took a position in a hospital. Other demands of the workplace included high nurse-to-patient ratios, mandatory overtime. Many students were unprepared for the demands of documentation, which as somebody who works in clinical informatics is my other passion. I mean, why are we continuing to document what we document in nursing? Rather than really focusing on what needs to be recorded, when does it need to be recorded, and how can we do that efficiently. Lack of respect kind of echoes back to the colliding expectations. New nurses experienced outright criticism, arrogance, rudeness, lack of respect. Most often, physicians were the offenders, but they also face that kind of behavior from seasoned RNs and even from executive staff. Then what's interesting, and this is really such an echo of Marlene Kramer's work, they also talked about being hopeful about the future. So just as Marlene Kramer spoke to reality shock resolving as new nurses determined that they could be part of the solution, so nurses now, 35 years later, described exactly the same thing. that they thought they can be part of what changes in our profession, that they can help to drive the change. They recognize that the transition is something that took time and that they might have anticipated a bit better, but they want to help improve both the work environment, nursing practice, and the profession overall. So I think that's remarkable, that we should stay so hopeful despite a really, really difficult time. Speaks to the strength of the human spirit. So nursing residencies are noted to be positive for several reasons, and some of the purposes that have been described about them are, first, that they reduce turnover in the first years of practice. The statistics on how many nurses leave the practice setting in their first year is a little bit hard to get at because that's an awfully wide range. And I put 35 to 61% leave an organization in the first year, but now I've read something more recently that said 25 to 60%. So I'm not exactly sure where that statistic is. Whatever it is, if it's 1 in 4, that's a lot. And if it's more than that, that's even worse. So it's an important reason to adopt a residency. The thing that people fall to first off, I think, when they talk about people leaving a role in the first year of their work is how much that costs the organization. And costs are hard to calculate. The number I have down there is 82 to 88,000, but I read something sort of recently that said when you're really thinking about that cost of replacing a nurse, you should talk about what it costs to offboard them, then what it costs to replace them, like do you need temporary workers or overtime from other staff in order to fill this now vacant position? What does it cost to recruit? Then what does it cost to retrain the new person that you've recruited? So that they say you should take 100 to 150% of the annual cost of that nurse's base salary that you've lost. That's dollars and cents, but I think it would be a terrible thing to lose track of the cost to the individual who leaves a role, feeling unsuccessful, feeling a failure, distressed from a moral perspective, and very anxious about their future. So while the dollars and cents probably can be calculated with greater ease, the mental health issues for the young nurse are, I think, as important to talk about. The second purpose of residency programs really is to create a bridge from the preparation, across the preparation to practice gap. I think that it is especially a concern for those of us who practice in nursing specialties, so in nursing of children, so that we can really help to new nurses to gain the skills they need to be successful in specialty nursing practice. Also, to help cushion that transition from school where we're able to focus very, very closely on 1 or 2 patients to a career where you are facing the simultaneous demands of many patients while also experiencing often your first time of shift work, and knowing that if we can reduce some of the role stressors, that we can improve satisfaction. And then there finally is a focus on the improved quality of care and patient outcomes that are likely to be the benefit of good transition programs, because we can make care safer. Care is very, very complex in this era. The amount of knowledge that nurses need to assimilate is pretty phenomenal. So a few words about some different program designs. The University Health System Consortium, or UHC, and the American Association of Colleges of Nursing partnered to develop a residency program that is based on the Essentials of Baccalaureate Education in 1998. It also provides, through the Commission on Collegiate Nursing Education, a model for standards that residency programs should meet in order to be accredited. So they offer the same accreditation for residency programs that is also available colleges of nursing or schools of nursing. Their program focuses on skill acquisition, empowerment, professional development, and it's utilized at 2 children's hospitals that I am aware of, the Children's Hospital of Philadelphia and Cincinnati Children's Hospital. Are there others? Is that accurate, Chop, friends? Cincinnati? And at Vanderbilt. That's right, that's new. That was beginning to happen right when I was getting ready to leave there. Excellent. The AACN, this is a brochure that they provide nursing students, what every nursing student should know when seeking employment. One of the things in the upper, I don't know if you can read this because the slides seem so washed out to me, but in the upper left-hand corner, they're urged to look for organizations that demonstrate that professional development support is there for nurses who work there. And one of the things that suggests that they do is to look for programs where there are internships or mentorships available to new nurses. So they promote that actively. Another program that's commercially available was developed by Versant. Versant is a word that means to be well-informed or thoroughly knowing. It's a derivative of a word. It was developed initially at the Children's Hospital Los Angeles and sought fundamentally to improve the quality of patient care by developing, improving, sustaining professional nursing, one nurse at a time. It's a comprehensive education and training program that is designed specifically to transition new nurses, so it combines skills acquisition with professional education with a preceptor, and then formal mentoring and professional development opportunities. Most recently, the National Council of State Boards of Nursing has entered the residency discussion with registered nurse transition to practice programs. Everybody knows that the role of the Board of Nursing is to protect the public's health by overseeing and assuring that nurses in practice are providing safe care. Their transition to practice program is intended to be collaboratively implemented with education and practice, but through the regulation of nursing licenses. It's intended to be a very inclusive model, so that it is intended for all healthcare settings that hire new graduate nurses and for all educational levels of nursing, including practical nurses, associate degree, diploma, baccalaureate. They're clearly not taking on the entry to practice issue. They're being inclusive. Kentucky, North Carolina, and Vermont were among the very first states to implement statewide models for transition to practice programs. A little bit more about the State Board of Nursing model. They identify safe care as a real impetus for their program development and display rather prominently that mistakes happen to new nurses. As many as 40% of new nurses report making a medication error. They report that newly licensed registered nurses feel stress and anxiety, and that stress is a risk to patient safety. And they report that 25% of newly licensed nurses leave their position within the first year of practice. Their model looks like this, and I know you can't see that on the slide, so hopefully you can see it, at least a very little picture of it on your handout. What they intend is that the new nurse would first obtain her license to practice, his or her license to practice, by taking the NCLEX exam. And then they would enter a period of orientation in whatever healthcare setting they are practicing in, and emphasize in this piece that a relationship with a preceptor is a key part of the equation. They imagine that most preceptors, and they see this as an opportunity to partner with academic organizations in training preceptors. How do you help a new nurse to learn how to practice? What's your role as a supportive supervisor of new nursing practice? But that relationship is key to successful orientation. And then they begin what they call transition modules, and those include things like specialty practice, communication, safety. The list that's in, well, I can't point at this and have you see me, the list that's in the biggest portion of the screen there include competency and quality safety, education in nursing. And all of that would take a period of 6 to 9 months with continued mentorship for a full year, and then they would relicense. So they would have to present evidence after 1 year of practice that they had successfully completed a transition to practice program before they could license for another year of practice or beyond. So they would require participation in the transition to practice program. And then finally, there are an awful lot of independent hospital programs. The state of Missouri has just recently become an action coalition in the Robert Wood Johnson Foundation effort to define the future of nursing. And so we have taken on, we've decided that nursing residencies are a topic that we really want to look at across our state as part of the education initiative. So we've looked at what hospitals in our state are doing that are part of the Missouri Hospital Association and surveyed, I think it was 88 hospitals in the state. I was just flipping through some paper to see if I had the actual numbers, and I don't, but I can remember them pretty precisely. 70% of Missouri hospitals do not offer an internship, only 30% do. And of the 18 hospitals that do offer a residency program, one uses the AACN UHC program, one uses Versant, one uses the State Board of Nursing model, and all the rest have independent hospital designed programs that they have developed organizationally themselves. Most often, they say that cost is the reason that they can't purchase a program. And then for some, they also mention that programs designed for baccalaureate nurses don't fit the mix of nurses who they hire in their organization. But as a consequence, we have an awful lot of programs with, I'm sure, a tremendous amount of variability, both in content and in the length of the program, although almost all of them speak to the fact that they want skill acquisition and professional development to be key features of the programs that they provide. And as I mentioned earlier, the CCNE does provide accreditation guidelines for independent residencies so that we could standardize by looking at programs being required to meet that accreditation credential. So some of the impact of variation, we know that they're inconsistent in terms of the results that are found from them in terms of reducing turnover, in better preparing newly licensed registered nurses, improving job satisfaction, doing anything about professional empowerment. We do know that there are some successful program characteristics that we can glean from evidence of success. Preceptor matching and the preceptor role is one characteristic that programs describe that are successful. And then in addition to your preceptor, a new nurse is having present to him or her an advisor or mentor is a second role that's recognized to help create professional self-confidence. Successful programs also balance skill acquisition with professional development, and that professional self-concept development is key to reducing role stress and also increases retention. And that careful attention to the workplace is also necessary in order for any program to exceed. So you can't have a program be external to the demands of the actual unit the nurse is working on, so that assuring that staffing is adequate, that the unit culture is positive, and that patient assignments are made with care are really important features of successful programs. So you heard this morning, and I won't belabor this, that we did talk with academic baccalaureate programs about nursing residencies, and this is, again, you saw this morning on the slides that Jan and Anne-Marie presented, but programs that believe they meet pediatric nursing objectives with fair ease, think that their graduates are better prepared to provide pediatric nursing care. That makes a lot of sense. And those who had trouble meeting pediatric program objectives then also think that their graduates are less well prepared. And again, you heard this morning that graduates perceived to be well prepared tend to be associated with, or tend to be graduates of schools affiliated with academic medical centers. Again, these slides you saw this morning, a lot of faculty, probably about 60%, found it somewhat or very difficult to meet pediatric program objectives, but still feel that their graduates are pretty well prepared to care for children, adolescents, and their families. When we asked them specifically if they thought that a pediatric nursing residency would be helpful to students finishing their programs who wanted to work in pediatrics, you can see that probably close, a little bit more than 80, maybe close to 90% of faculty recommended nursing residency programs for people wishing to practice in the pediatric specialty. And then we asked them how long they thought programs ought to be, and most of them, you can see, landed on the 6 months. With, I guess, the next greatest percentage recommending a 12-month program. And that is pretty typical about programs in this country now, that they're 6 to 12 months in length. So pretty consistent there. They saw that recommendations, they told us that recommendations for a residency program was not related to the difficulty they perceived in meeting pediatric program objectives or how well they perceived students to be prepared in pediatrics. I think that's really important. The idea that a new nurse is going to be prepared without some sort of transition program just makes no sense to me. And I suspect that we might be, if we can find a way to do this effectively, really at a point where we won't be talking about reality shock in another 35 or 40 years. Maybe we will propose a solution and actually implement a solution that can impact a phenomenon we've been describing for forever, it seems to me, for my whole career. So this last slide, I'm hoping will maybe guide conversation a little bit perhaps this afternoon, but more definitely tomorrow when we talk about pediatric nursing residencies. Just some questions for you to ponder. Are we designing residency programs because there are fundamental shortcomings in nursing education? Is this transition program, what I suggested it might be, really an answer to the reality shock we've been seeking to address? Who should pay for residency training? In Missouri, hospitals who said they didn't have residency cited money as the #1 reason. And some offered residencies only to staff who were identified and kind of handpicked for the program. Some organizations said, well, they could only offer residency to about 1 in 4 new nurses that they hired. So they weren't able to, they perceived the cost to be more excessive than they could manage in order to offer a residency to everyone. Do we really advise that organizations individually design and develop their own programs, or is there some better way to standardize or recommend standardized content? Should residency programs be required to be accredited? How might we use participation in a residency program to further build individual nurses' career development? Do we offer continuing nursing education credit? Might it lead to certification in a specialty? Is it possible to form partnerships with schools of nursing and even offer academic credit for work within a nursing residency? Are there outcomes that we should be measuring across all nurse residency programs? Could we organizationally advise or collaborate on content for pediatric residency programs? What about non-acute settings? What about community hospitals where children are also cared for, or critical access hospitals where children might be seen prior to transport if they need a higher level of care? What do you think about the state boards of nursing controlling the transition to practice programs? You almost have to give Jan sedative medications when she starts to talk about the state boards of nursing controlling residency programs. And then if we require this, who pays? And if someone can't attend, what becomes of them? So there are lots of good questions. Well, no. We have some time, but remember, this is your nap time. But we have some time, and I'd love to start the discussion here, because we really cannot do all of the discussion tomorrow at just one table. So, questions?
Well, if you look at the funding, my father always said the more degrees you had, the less common sense you had. Sorry, I got the mic on now. If you look at how medical residencies are paid for, they're paid out of GME monies, which come out of Medicare, which indirectly come out of taxes. So, rolling right along into the new Patient Care Act, one of the things that's in there is a provision for the Center for Innovations that is designed to improve quality. You have just made an excellent case of why nurse residency programs improve the quality of patient care on a variety of levels, both direct and indirect. I would like to propose that it be proposed that a pilot study be done to actually use some of the anticipated cost savings on the Patient Care Act to fund nurse residency programs in the long run. Now, the uphill battle is that we're pediatrics, and it comes back to the Medicaid, Medicare, and how that's analyzed. But I do think that you could it would be an interesting case to try to make, because one of the reasons that medical residencies exist is because when they graduate from medical school, they're not ready to practice medicine. So, and with the increasing complexity in nursing care, I think that we can make some of that case as well. So I would very much like to see that be someone take forth and head that initiative and see if you could get some pilot money, it's big pilot money, to try that. And then it become ingrained into the federal system in the way others.
I guess what I would like us to, I'd like us to think about not doing is making it mandatory for everybody, finding ways to tailor these. If you put in a 6-month or a 12-month, some of those nurses are going to be ready to move on at 3. Some are going to take a 1.5 years, which maybe you don't want to keep them around if they take 1.5 years. I don't know. But we always tend to regulate ourselves, and then everybody's treated exactly the same when there is just no way that they are the same. And if there were some way to figure that out and then sort of tailor some plan, and you could, I suppose, have it competent. This just feels like we're going down a road towards second licensure that just is not a good idea at all. I don't know. Like, why aren't the current hospital programs working? And
I don't even know that we can say they're not working.
Yeah,
I think we can
right.
only say the results are inconsistent,
Okay.
and
so we don't know what's broken
but
yet.
we don't really know what's broken.
Okay, whoa, okay. Yeah.
Yes.
My other hat that I wear, other than the Pediatric Endocrine Nursing Society hat, is that I'm involved with ambulatory nursing. And I have about 14 areas at Children's National Medical Center, kind of right uptown here, that I manage not only from APNs to very basic nurses. What I've found is that right now, we've been challenged and asked, well, can you take new grads in the ambulatory areas? And the question became, well, do we have a residency program, or is our new grad program able to do that? And as I even looked at the curriculum, I said, no, absolutely not. It's not ready for my ambulatory nurses, but it's definitely a place where I think we need to look. Because as I heard this morning, so much of what they're prepared in their programs is all inpatient clinicals and whatnot. And if you look at healthcare over the last 10 years, guess what? Everything moved, a lot of things have moved out of the inpatient over to the ambulatory side. I mean, and in a way, when I saw the question, what about non-acute care setting, I can tell you that I have clinics that are just as acute as my floor, as the floors. Yeah, those nurses see 3 patients. I have nurses that triage 90 patients in a day and have to do rapid assessment. And it's a different skill set, but right now we're looking to see if we can bridge that gap for some new grads, but it really is a challenge. But I don't think anybody's really looked at that concept, whether it's the baccalaureate programs or even associate degree programs, preparing nurses in a different venue, and and really providing that support that they need to go into areas that are growing, I mean, in unbelievable manners. Because even as I look at the finances of our hospital, because I am administration, you see over the last 10 years, this little piece, this little chunk was ambulatory. Now it's 50% of our budget, and the revenue that we're bringing in. So I think we have to be able to take these residency programs and expand it in different ways.
I absolutely agree with you. I mean, our ambulatory services have really turned into day hospitals.
Right.
So
We're doing procedures on an outpatient basis that children were admitted for 5 years ago. So it's being done by nurses and nurse practitioners, physician maybe 1 to an entire clinic staff. So it's a dynamic. It's actually pervasive in the subspecialty areas because it's a moneymaker. And if we can do procedures and we can show that we're going to make the budget, then the hospital is all over it. So I think that's a revenue source for you as well, though. I mean, so you can look at it as a positive as well as not.
yes.
You can hear. When we started the residency program at Children's Hospital Los Angeles in '99, about a year afterwards, the comment came up from our ambulatory clinics is we would love to take on new grads. And so we did trial it for about a 2.5-year period of time, where our Hemont clinic was the one that volunteered first and took on a new grad. And the first time they took on 1 new grad, and the 6 months was not long enough, so we increased it by an additional 3 months and 9 months. We actually increased it a little bit longer than that. And the feedback from the first new grad was, oh my gosh, I can't do this, because they didn't have any of the experience of triaging phone calls, working with physicians. It was very quick. They had to be on their toes, and their preceptors really couldn't teach that part of it. It came with experience, and the majority of our ambulatory clinic nurses were our floor nurses that then went over to the ambulatory clinic side. So we attempted it again in Hemont, and it didn't work a second time, and that nurse actually left our facility, unfortunately, because it wasn't the right fit, and we extended it for a full year, and it just wasn't anything that the nurses weren't able to to teach during the residency or the time. It just 1 year out of being a new grad was just not enough time for them to be able to take on the load that was expected of them in a very acute hemonc clinic. So we attempted it one more time in just a general peds clinic, and within 3 months of that, the new grad was like, I can't, I need to. So based on feedback from them, and we just didn't pursue it any further, we waited. We are doing it in our OR, and it seems to be working where they get an extended length of time in the OR, and that area is working where we would never have taken a new grad before. And but ambulatory was a tricky area because you can't teach someone, you know, how to be quick on their feet and answer phone calls and talk to physicians and do all that when they don't have that experience to tie all that in.
Yes.
So we have attempted that. In 2006, we hired about 350 new grads that year. In 2007, we started seeing the need for ambulatory movement into the ambulatory setting, which is exactly as you described, fairly acute. But we used the same, our model of care is the synergy model, and we used Patricia Benner as our clinical ladder. We used the same concepts in the new grad program, but we used an apprenticeship model in the ambulatory care setting. So there was really one-on-one, not just with nursing staff, but with the physicians as well. So the plastics clinic is the best example I can give. We oriented this new grad not only in the OR, in the clinic, and on the inpatient setting, but we kept shifting her around with the same people. And it was very successful. And then we did it in urology with a very difficult team. Same model, shifting them around, same concepts of care, and it was very successful. But it is extremely difficult, and you have to be protective of it in a way that you're not as protective in the inpatient setting. We're about to do it in a setting where we are orienting school nurses, and I feel most excited about that because we've never gone to that place before. So it'll be interesting to see how that works. We had the most difficulty in oncology because we cross over to a setting which is unionized, and that was very hard to do that orientation over there, but we've had some success with it.
Mm-hmm. Yes.
We use the UHC AACN model, and we do orient new grads everywhere. The nurse residency model isn't our only model of introducing people to practice. So the only place we've really had trouble with it has been in primary care, where just the scheduling and staffing and how few nurses there are in primary care has made it a little more difficult. But all new grads come through the nurse residency program. But there's also precepted time to learn the skills and the culture and everything else about your home unit. So hasn't been a problem.
It has worked well on our critical care areas and in our ORs, but on some of the general floors, the different level of preparation of the nurses coming in is so different that to try to get them in one residency program, some of them were more extended students on different units, and some of them came in from very little pediatric practice. So it has been very difficult to try to start a program with a common level.
Yes.
One of the things I just wanted to comment on was in the residency that we've developed, we did use the standards from CCNE, but one of the things that we did was we created a rotational program. So they don't start in a specific area like ambulatory or, and that's their assigned area. They actually rotate for 5 weeks through 5 different units. And then we go through a matching program so that they know whether or not that ambulatory setting, we've actually had one very successfully go to dialysis, which was not one that we would have typically thought a new graduate nurse would ever go to, was it? And it was an amazing match. She's been there 3 years now. And the fact that they are rotating around has really made a big difference once they get to their matched unit for the second half of the residency. Another comment that I wanted to make was the slide that talked about how long should a residency be. Since we went with the model that CCNE has for their standards, we went with 12 months, but we did this as a research study, and we used the state trade anxiety inventory to measure their stress, and it was statistically significant, but that did not happen until a full 12 months in the program. We measured them at baseline, 6 months and 12 months, and they actually, at 12 months, their state anxiety was lower than their trade anxiety, and that was not with the first cohort alone. We thought that, oh, what a fluke, but every single cohort, individually and collectively, when we put them all together, now has a similar finding. So.
Wow. So just look at this, and I have the sense that what we know collectively in this room would not be true just for pediatric nursing residencies. I mean, this has to be true for transition to practice in whatever area, even the big bad med-surg nurses. Yes. Ann.
I don't know that much about this program, but I know we have a VA Academy, and I know they look at the VA Academy as transitioning those undergrads into more quickly into the role of a staff nurse through that.
What is VA, like the Veterans Administration?
Yeah, the adult people.
Yeah, I just didn't know if VA also stood for something. The Veterans Administration versus value analysis or. So that's their model for?
I don't know enough about it.
Huh.
I'm just saying, you know, I see that from the undergrads. I'm not that familiar with what they're doing in the VA Academy because it's those adult people that went to war. But when I talk to the undergrads who are in my program, they feel more of an affinity to work with those populations and have a greater degree of comfort. I just suggest that out there.
Yeah, it might be a good thing to look into.
I can tell you a little bit more about the VA Academy because we have a liaison committee between the VA and AACN, but it's my understanding that the Academy basically partners academic programs and schools with VA institutions to develop opportunities for education and training, similar to what they've done with the medical schools. There's so many affiliations between the medical schools and the VA. So the focus is on education, but I also know that the VA is developing a post-graduate or post-entry residency program that's going to be modeled similar, and I believe, to the UHC AACN one. So they are working on both.
Anybody else? Oh, excuse me, Dr. Wyatt?
You know, the issue of nurse residency programs is probably the one recommendation on the IOM report that gave me the most heartburn. Because the first statement under the record, well, first of all, it says implement nurse residency programs. And all the rest of the recommendations really were built on large, strong foundations of the fact that APRN scope of practice is fully, nationally consensus-based, national certification and standards are there, so let's recognize the full scope. Let's empower nurses to be part of teams. Let's get everybody to the baccalaureate level. But this one, this implement nurse residencies, the first thing out of the box is state boards of nursing should do this. That's the first statement in the IOM report, which I think is just not appropriate. My concern is that we are designing, as Janice beautifully pointed out, there's so many different varieties out there, and the National Association of Children's Hospitals calls it resiliency programs. There's a title for you. Then their residency, they're also transition programs or extended orientation. They're called preceptorship mentorships, and they're called internships. So they're called all kinds of things. There are no other, the CCNE has developed a great deal of accreditation and standards associated with it. but they've set up a fairly rigid requirement that you have to be a baccalaureate nurse in order to go through it. You can't be an associate degree nurse, although when you talk to Jen Butlin, she says, you know what, they do have the associate degree nurses and so on, but we don't ask for a report on their performance. So we're only collecting data on the baccalaureate nurses that go through this. I've also talked to folks that says by the 12th month, the attendance at the required classes and the preceptorship, mentorship kinds of things, sort of just the attrition begins to sort of slide away in some programs, because there's no requirement for accountability and outcomes reporting necessarily. So here we are, have this IOM, implement these things, and I'm still saying, what the hell are they? What are we implementing? What are our standards? What are our expectations? And we talk about the number one, again, recommendation is that we want to improve retention for the employers. And my first question was, what if it's a crappy employer? Wouldn't you want the nurse to get the hell out of there as fast as they can? Because there are situations, and I can't remember who it was, but an individual talked about moral distress. It is an important concept in nursing in which we teach them appropriate ethical behavior. They get into institutions in which there are pressures to push them towards unethical decision making. And so the moral distress that's inherent in that is the reason they quit. Not because of, but the moral distress factor is a critical variable. Plus, we're talking about women of reproductive age, for heaven's sake. So they're going to leave the workplace, many of them, for that reason, or their significant other gets transferred. So all of those soft reasons that people transition during a particular lifespan really needs to be accounted for somehow. So
and I think most organizations really do account for that, because they talk about avoidable turnover versus just turnover that happens because of life events.
Right.
So I think organizations have a
yes, I think it would be fabulous for every brand new nurse to have a mentorship, preceptorship program, and that's really when Michael Bly talks about residency programs, and it was sort of his bailiwick within the IOM report. He was on the panel, and that was sort of what he owned. But he has already conceptualized it, not necessarily as a series of curriculum skill set stuff. To him, it's all the acculturation within an institution and the leadership and those soft factors. And it was interesting, I was back in December when they did the full IOM implementation, we all broke out into our sessions and we went, so I went to the residency one, not because that was, but I just wanted to listen. And the APRNs in the group were going on and on, no, residency's not necessary for APRNs, and someone said they were, and someone said they weren't. And then somebody said, nurse residency is really all about the warm fuzzies that we need to give to people. That was a quote. And other people said, no, it's skills. And I'm thinking, ooh, implement nurse residencies right in here. And it's like, I think there is a need to really circle the wagons in the nursing community to better understand what it is that we expect nurses to produce through this rotation into practice. And I worry that we're going to set up a series of requirements for these new nurses and never give them credit for making these accomplishments, either career ladder credit or somehow academic or credit towards certification or continuing ed or what have you. We're setting up a series of expectations for performance, just like we do in the academic setting, in which we're never really measuring whether they've, according to a national consensus-based standard, never measuring whether they've made a true impact. I think it's very important, but it's the one area this IOM report, as I said, gives me heartburn.
So is anyone surprised that Jan feels passionately? Yes.
No, I'm not surprised that Jan feels passionately. However, I just want to say that, I agree that there's lots of research we need to do on these, but I don't think it's a reason to dismiss them out of hand. And I'm delighted to hear about all that's going on. But when I, as an APRN, read the report and read about implementing nurse residency programs after pre-licensure or APRNs, you know, as an old NP faculty person, I think you have a tremendous cohort of faculty who over the years would have salivated over the opportunity to educate NPs with a residency at the end of their program. I mean, students, faculty, all have said, I think, excuse me for generalizing, but we have all seen the value in condensed immersion clinical experiences for APRNs. And the reason over the years that we have not moved that way is certainly financial, and also for students, and also because the opportunity to put APRN students in an immersed setting day in and day out, 5 days a week for 8 weeks or 6 months or whatever it is not really, has not been available to us in terms of, so the idea that there might be, you know, if you have a recommendation like this, it could be that there will be GNE monies or something down the road. So I just saw it as an opportunity for a new way of educating and APRN students that, so I don't, you know, I know it's not mandated, but I'm open to the idea that perhaps for the first time we're looking at the idea that maybe APRN students should be given some of the same benefits for an immersion kind of training at the end of their program that our physician colleagues have always been given.
Couple more comments?
This is a little off the cuff, but we're a small organization and very specialized, and so some of our, we call them founding mothers, had decided early on that we needed an intense preceptor program, and so we applied for a grant, got it. It's been very strong and very popular, and the nurses that go through this preceptor program, first it was just RNs, now we've increased it to an RN track and an advanced practice track. They're paired up with someone that mirrors their sort of practice area for 3 days of intensive mentorship. And it's usually a leader that they're hooked up with. And I think we have a really good recruitment for it and retention in our organization and in our field. So that just speaks to the ability to identify someone that needs mentoring, mentor them properly and intensively, and then to encourage their leadership ability in that field. So just wanted to add that.
And I'll just add, the relationship doesn't end after 3 days, it continues.
Oh no, I mentor them, and then at the conference we hook up with them and introduce them to people and get them involved in committees, and it's, I've had probably 10 preceptees, and all of them are still emailing me with questions, and so we have a really nice collaborative, and again, we're small, but I don't see how that model can't be broadened, so at least in some respect.
I just wanted to make 2 comments to build on what Elizabeth said, and that is, I think now that as we're looking for the IOM report stating that we need to have nurses practice to the full scope of their education and their capabilities, I think that that makes an argument then for helping to make sure that we mentor them and precept them and move them into practice and provide them that opportunity. Same thing at the APRN level. I know that in the APRN community, we've fought a long time against, as Jan said, against having anything postgraduate, whatever you call it, a residency or whatever. But I think that in listening to the conversations, when you're talking about asking APRNs to be fully licensed as independent providers, that maybe we need to start looking at some of the opportunities postgraduate for different kinds of, to work into a full independent license. And I know that's heresy in a lot of APRN communities, but I think we need to be open to have the conversation. And I just wanted to comment, we have looked long and hard and argued about using graduate nursing, you know, CMS, and making graduate nursing education funds for this kind. In fact, when the residency program was developed, that was one of the premises, that we were meeting the guidelines that would meet the criteria for GNE funding, and they keep changing the rules. And I'm not saying it won't ever happen, but they keep changing the rules on us from CMS so that we can't get the monies. But you know, we'll continue to work, and anybody else can continue to work on it.
Mm-hmm. So I guess what I'd like to do, maybe just to wrap up, and Mary Jean, you can maybe wrap us up even better, but will you think, especially ponder a little bit overnight what the IPN can do as a group that brings together nurses from all kinds of pediatric backgrounds in order to have a voice in this discussion. I'd be really intrigued to hear more from those of you who reacted as Jan did, with passion about whether or not it would be regulated through our state boards of nursing. So, because I think we need to be prepared to take that on. So I really ponder that a little bit overnight.